meeting of the Health and Social Care Scrutiny Review Group. Okay, let's get started. Do we have any apologies for absence?
Apologies from Councillor Ahmed, who's being substituted by Councillor Amjad Ali.
Cool. Minutes of the last meeting, 8th of January 2026. Those who were there, are those a true and fair reflection of the proceedings of that meeting? Thank you. Any disclosures of interest?
None, Chair.
Urgent business?
And none, Chair.
And references from committees or other bodies?
None, Chair.
Thank you. I have a couple of things to mention in my update. I had a meeting with Corporate Director and Service Directors of Public Health to discuss future potential items to come before this committee. And I also had a meeting with the BLMK ICB's Director of Primary Care to discuss the presentation of primary care access reports in the future. And we specifically spoke about the primary care access report for the April meeting. Okay. Go on to the first report, item number 7, update on maternity services at Bedfordshire Hospitals NHS Foundation Trust. David, if you'd like to introduce yourselves, then carry on.
David Carter, Chief Executive of Bedfordshire Hospitals.
Liz Lees, Chief Nurse, Bedfordshire Hospitals.
So if I just give a brief introduction and then pass over to Liz. The report we received was referenced to an unannounced visit made by the CQC to our maternity services back in June. We're obviously very disappointed that the report that we've now received does not change our rating, which we were very hopeful that it would do so. However, there were some real positives in the report that we've received, and one of those was that the CQC, all of the women that the CQC spoke to during their visit, all of those women were positive about their experience and about the way in which they've been treated. The CQC also referenced some real positives in terms of our multidisciplinary working and also very good engagement from our staff with the process itself. However, there's a number of areas that they've picked up, and a number of those related to our estate, but that was at Luton before we moved into the new acute services block, which happened in November. So obviously many of those issues have now been resolved through that process. But many of the issues related to issues such as the closure of incidents, the levels of appraisal of staff and levels of training. And I think that it's fair to say that those issues are ones where we absolutely were determined to try and ensure that we reached a required standard, but there was a balance to be struck in terms of our making sure that and all of those issues require us to take staff out of the clinical environment for training, appraisal, for incident clearance and so on. And we didn't feel that we could, in all cases, do that. So sometimes, for example, we cancel training when there's particular busy on the shop floor. And we have to remember as well that maternity service is one of those which has the most volatility. Some days are really busy, some days not so busy. And when we have a process, when the unit is particularly busy, sometimes through that escalation process, we do things like cancel training. In recognition of that, one of the things that we've done recently and since this report's been published is last week, our board did sign off a significant increase in our midwifery and obstetric workforce, and Liz may talk a bit more about that. But I think it's fair to say that certainly some of the work that we've done more recently, and this is referenced in the report, is that looking particularly at Luton, not so much at Bedford, but particularly at Luton, the complexity of the women that that presented to our unit. Now, obviously, we know that we've got, for a couple of reasons, one of which is that we have got a tier 3 neonatal unit at Luton that deals with the most complex babies, and the what that means is we draw those women in from outside, and therefore Luton becomes a more risky unit. But also we know because of our demographic, we have got particular risk issues. But I think even we were surprised when we did the audit that's referenced there, the high numbers of different risk factors that our women have. So, for example, where English is not the first language, where obesity is a particular issue, and also mental health. But also it's the combination of those factors. And it's partly the reason that we think some of the workforce tools that are used don't necessarily pick up the particular complexity of our women. So one of the things that we have to do is make sure that we can both keep our units safe, but also make sure that we have the that we can release our staff for things such as appraisal, such as training, and for incident clearance. So that's the broad summary of where we are. I'll just hand over to Liz to talk through some of the improvements we've made since the report's come out. But I think it is also important to understand the context in which particularly the Luton unit has.
Thank you, David. So about January last year, we engaged on a perinatal improvement program within the organisation, and we had some support. We commissioned some additional support with 2 improvement directors to help us shape that program of work. So that started really around about March time, working across the organisation, not just in maternity, focusing on improving our user experience, looking after our staff, quality and safety governance, and improving clinical care. And those were all led by some of the most senior managers within the organisation. And whilst, as David said, some of those improvements were acknowledged when the CQC visited, I think we have definitely made some significant improvements since then. They are highlighted in the paper. I'll just go through a couple of the key points. Fundamentally, the most important thing is in November last year, we moved into a new building in Luton and Dunstable, which is a new purpose-built building where we moved our maternity services and our neonatal services. And we are 3 months post moving in there. So that's a really positive thing. And it was quite a phenomenal achievement for staff to move such a large service, which essentially happened over a 12-hour period. So that's quite a phenomenal achievement. We have really tried to focus on the health and well-being of our staff, understanding that it is really busy in our unit and our capacity is constantly outstripping our demand, hence the requirement for some additional staff, as David has alluded to. So last week, the board approved a sum of 68 whole-time equivalent additional midwives and a number of medical staff on top of our current establishment based on a staffing review that we did last year. We have been doing a lot of work on our culture of our services as well. That was alluded to in the first CQC report from a couple of years ago. And we have a whole work stream dedicated to making sure staff feel able to speak up. And we have co-produced an incivility and anti-racism charter. So that was done with our staff and with our EDI leads, initially within the maternity unit, but we have rolled that out across the whole organisation. You will note in the last year's CQC report, they touched on concerns around our mandatory training. We're now at 90% for that. Our appraisal rate has much improved. We're not quite at 90%, but we're on trajectory to do that. We've also have a new patient engagement framework, which has been launched as part of our perinatal improvement programme. And our patient experience midwife, along with our MMVP, are working really closely to make sure that we have the voices of the families that use our service and our staff front and centre of everything we do, doing a huge amount of community engagement in that regard. I'll just pause there because I think a lot of the improvements are highlighted in the paper. We know it's going to take us a little while to recruit. I think we've only just approved that at board, that number of additional staff. It's going to take us quite a while to approve. That's a large number of a large workforce. So we have a plan and a workforce. We're just developing our workforce strategy to see how we would do that, because it's going to take us a little while to do that. Focusing on recruitment and retention of those key staff in order to support us for the future. Whilst I focus on Luton, the other thing where we have invested is in our triage unit at Bedford Hospital. That was highlighted in the report from last year as well, and that issue has been resolved with additional resource within it.
If I could just add one other point, just in terms of the overall context that we operate in. We know that the birth rate is falling nationally, and the fertility rate is coming. Luton, I think I'm right in saying that Luton has the highest fertility rate in the country. And one of the things that we've given us particular challenges is that whilst other maternity units up and down the country are seeing reductions in births, in fact, we were one of only 5 trusts in the country which have not seen a reduction in births. So that has been a particular pressure for us. And obviously, we don't expect to see our births coming down any further, given things like Universal Studios, Tempsford potentially in the north of our patch, and even the growth around here, and also the high fertility rate in Luton. So that's a particular factor that we've had to put it a different way. I think other maternity units have had a reduction in births that have alleviated some of the challenges, particularly the post-pandemic challenges that we've faced in terms of the service, and the fact that I think the growing acuity. One of the national factors that has caused more challenge for maternity units is the growth in the caesarean section rates for lots of different reasons, including some of the risk factors. For example, the fact that we now see the age when women first give birth to be increasing, but the C-section rate has gone from something like the early 20% of births to something more like 50% now, and that is obviously means that women both spend more time in hospital, but also use up more resource. And so that's one of the pressures that is pushing us to need to invest further and further in terms of our midwifery and obstetric medical staff. Thank you.
And I just wanted to add, so as part of our improvement journey, not only do we have an improvement director working with us, we're part of the national support programme. So we have a team of additional experienced midwives and consultant obstetricians that are external to us, that are working with us, that have got experience working nationally as well. So I think that just helps us bring in best practice from other organisations and making sure that we're constantly reviewing everything that we do. And that's been extremely helpful, certainly with some people that have had experience of more complex units, like Luton and Dunstable in particular.
Okay, thank you. Before I open this up, could you clear just something that I'd like to clarify is how are maternity units funded? I mean, you were talking about the increasing the likelihood that Luton is going to have an increasing number of births, whereas most of the rest of the country is having a decreasing. That number will be decreasing. So my understanding is that the funding won't reflect that disparity.
That's correct. The situation has changed. Prior to the pandemic, prior to 2020, maternity services were funded on effectively a tariff basis, where we received a funding for each woman. The funding changed depending upon, or the funding was different depending on the risk of that woman, and also whether the woman had a caesarean section or a natural birth. However, since the pandemic, funding is effectively a block sum for the unit, which is basically reflected your funding prior to the pandemic. It's gone up with inflation, but it hasn't changed. Now, what that's meant is that most units in the country have had a financial benefit in the sense that their number of births have gone down, but their funding has stayed the same. Our births have gone up slightly. They haven't gone up massively, but our funding has not changed. And so some of that, I think the cost of maternity units has certainly grown. And the cost has grown primarily because the C-section rate is going up, because the acuity and complexity of women is going up, because, for example, the age at which women give birth has gone up. And also the particular requirements on us in terms of the standards that we now operate have increased over that period, partly to do with all the maternity problems nationally. So the position we've been in is not that we've received decrease in funding, but that we've not seen additional growth in our funding to cope with the additional costs. And other units have effectively had a benefit because their numbers of births have gone down significantly, and some of the units around us, but their births have gone down by something like 1,000 births in some cases. So that's the particular problem that we face. There has been a suggestion that there will be a return to funding for maternity units based on a tariff, but that's not happened. And obviously, we're particularly exposed because of the absence of that arrangement. We did write to the ICB last year, looking at making the case for additional funding for maternity, but we've not been successful in that, and we're having to make the investment this year without any significant funding specifically for maternity.
Okay, thank you. The other thing I would like to mention at this point is, I mean, we appreciate the work that's gone into compiling and presenting this report, but I think it would have been useful. The report you don't explicitly list the issues a lot of the issues that need addressing. There's, I think I find the reports quite general about a lot of the issues. For example, the start of paragraph 7 says there were some areas for improvement identified. I think it would have been useful, certainly for myself, if you'd have listed those issues and along with corresponding list of actions and improvements that you were putting in place to tackle those issues. And I think it would also have been useful to have the perinatal improvement program as an appendix.
That's helpful feedback. The perinatal improvement program is vast. It's got 1,000 activities in it, some of which aren't in any reports. They're things that we have discovered as we've gone along. There is a maternity, and we can certainly do that if that's helpful for next. I'm sure we'll be presenting at some point next time. It's we have a maternity improvement board, which we've had today, which is currently chaired by the ICB, and we have lots of partners involved in that, including Healthwatch Luton are invited to come to that, NMC, GMC, regional colleagues, CQC, and so we do share it very widely within that space, but very happy to provide maybe more of a list of things and actions if that would be helpful next time. Certainly appreciate it.
Yes, it would be. Yeah, thank you. Okay. Yep, Councillor Hussain, please go ahead.
First of all, David, thanks for the report, but this is an issue that we put it on the agenda specifically in light of what is going on in the press, is to ask you what you locally doing, because nationally the picture does not look very bright. Indeed, recently when talking about the other trusts where 55 children would have said, had it been an improved service. For me, really, the serious concern is that, you know, in the public's mind is the hospital, you know, the patient going to the hospital doing downstep are safe, and so is the children. So can you elaborate to us what has done? I understand the CQC is only done the 2 visits or 3 visits, but in terms of their inspection, this is how they do it nationally and all the other hospitals. So what is it that you've done since the first CQC inspection and now they visited second time? Have I got that right?
Well, there've been a number of visits over the years, but this is the first inspection since certainly the Luton inadequate rating first. This is the first inspection since then. I mean, I just perhaps ask this to talk again about some of the actions we've taken, but I think it's important also to reference the fact that the CQC generally doesn't it looks at the processes that we follow. But you've made a really important point about the sort of safety of the unit and the outcomes. So one of the things that we do, and in fact we were doing it this afternoon, was looking at the data on outcomes for the unit. And I think those are really important. They're not necessarily referenced in the CQC report itself, although it does reference that our outcomes are generally good, and that's the case. So if you take a couple of examples like that, so two examples of that would be, for example, massive obstetric hemorrhage and third and fourth degree tears. They're good examples of things that are an inevitable part of maternity care. If you take the first in terms of hemorrhage, our average is 3.2%, but the regional average is 3.3%. And for tears, our rate is 2.6% over the last 12 months, compared to a regional average of 2.9%. So I think when you consider that the complexity of our unit, for example, some of the outcomes that we achieve, I think that would be also interesting to bring to come back to Hosquith as well, because whilst we do have to get the processes right, we do have to make sure our staff have the right appraisal, and we have to make sure they have the right training. We have to make sure we cover incidents. It's also important to look at the outcomes we achieve. And I think that one of the things that we do as an organisation is constantly monitor those outcomes in order to make sure that we are understanding whether there's any areas that we are particularly concerned about in terms of safety. But those are the numbers for the Luton unit. They are definitely important issues for us to monitor in terms of our overall safety. Liz, did you want to just pick up on some of the improvements we've made?
Well, so I suppose David, you touched on this. The CQC report is one of many bits of information we get around our services, and I know we're here today to respond to that. But I think the improvement programme is much wider than just the CQC actions. It's difficult to sort of pick out individual examples other than the ones that are in the paper. But so the CQC focus on the sort of compliance element, and they're our regulator, and we've absolutely got to do that. But I think with the additional investment, we've got some new senior leaders in the organisation. We've got a new clinical director who is leading the consultants and creating a different structure in a slightly different way. I do think that we have got a good foundation for improvements moving forward. So I think that's sort of more of a general statement, and maybe if we could define the perinatal improvement programme a bit more clearly, you might get some different assurance on that, and I'm very happy to share that, because there are a vast number of things going on day in, day out, to make sure that we are not just being compliant for that moment in time with CQC actions, but actually that we're trying to significantly change the way that we deliver the care to our women that is sustainable for the future. And I think it's that sustainability is really the most important thing, because we don't want to be here having an inadequate maternity service. We want to make sure that we're going to be able to provide, we have confidence in our communities to provide a really good service. And even in the environment that we're working and the pressure on the teams, most of our women get a good experience. Now, it's not like that all the time, and we completely accept, and we try, when things don't go so well, we're trying to address them. But on the whole, if we look at our friends and family test at Luton and Dunstable, 97% of women that come through our service have a good or very good service.
Which is what you just said is where I was coming from, because somebody who's had a visit from our staff inspectors in children's services, and not one or two, 10 of them for a month, right? And you can just about imagine the pressure on the whole of the staff when they are around this building, as well as, and the important thing for them, for that inspection, is the voice of the child. In this case, in your case, is voice of the mother and the care that's given to the child. And in this case, that's what public is worried about, is what the care that was given. And on top of that, when there is an accusation of racism, yeah, and that really is a very serious thing for this town, which is very diverse, with the 52% of the mothers or the population is from the ethnic minority. So to us, that really needs to be, it is different to say any other hospital in Norfolk or Suffolk. Yeah. So for that reason alone, it needs to be catering for that particular groups of, parents and the children. So more importantly, the parents, where language is probably a major factor. Yeah. And that's not just with the Asian, but you've got the East European as well. So that we're not just talking about a particular, community. Yeah.
Just to say a couple of things on that. I think firstly, I think that's exactly right. When you look at the audit that we've got here, I think the sheer complexity, the fact that nearly half of the women did not have English as a first language, and I think it's important that maternity services are one of the most important services where the 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 woman plays a key role in determining how she wants her birth, how she wants that pathway to run, and therefore that communication is probably more important than any of the services we provide. Where in sometimes when people are having surgical operations, actually it's a bit more passive the patient in terms of their care. That they're directed by the clinical staff. But in maternity, it's supposed to be a partnership in terms of how the birth plan and how the mother wants their care. So it becomes more tricky, and that communication is more important. But what that does, and I think this is what we've found, is all of that takes time. It's a more resource intensive. It takes longer. It means that there's more pressure on our midwifery and clinical staff. And I think that's what's ended up with us having to recognise an organisation that we've got to put more investment in than other units would have comparatively. And obviously that's been difficult, going back to the point about the funding, in that we've not received any additional funding to reflect that. There's no additional funding for the complexity that we have at Luton and the factors that brings. So I think that's massively important. But I think, go back to my other point as well, in terms of the outcomes that we achieve, given the complexity of our population, I think there's a real positive in there. If you take my example around tear rates, we know that Asian women have got a high prevalence towards tears, but the fact that our rate, despite our population, is lower than East England average is something that we need to really monitor and understand, and also recognise that some of the outcomes our staff are achieving is very significant. I think the effect of the pandemic on all maternity users was very significant, in that what happened was that we lost a lot of those really, really experienced midwives. And sometimes, even when you're fully staffed, it's a very different thing to be fully staffed with a unit with a high proportion of newly qualified midwives and a unit where you've got all that experience. And so I think the fact that that post-pandemic effect has been significant. And also in relation to sickness, the NHS is still not back to the sickness absence levels that we had pre-pandemic. So there's still those hangover effects that we've got. And some of that is to do with stress and to do with mental health, as well as it is to do with physical illness. But in the end, we've got to make sure we've got the right number of staff to deal with all of those issues and all those challenges. And that's where we're getting to now, the investment that our board has signed off last week.
Thank you. Councillor Begum.
Thank you.
One at a time.
Perhaps I could just ask Liz to talk about recruitment, but I think one of the things is that recruitment was also that the ability to recruit midwives has changed over time as well. And we're in a slightly better position than we have now. But just in terms of that audit, I don't think it's a surprise in terms of our demographic. I think what's been a surprise and is the combination of factors that we've got, because also the women that we serve are not necessarily always proportionally represented in terms of our overall demographic in Luton. So we never looked at it quite in this way. We understood, and we understand what the demographic of Luton is. That's our catchment. We understand that in great detail. But looking at the way these factors interrelate in terms of that, I think was a surprise. The fact that only 10 women out of our 207 women had, seven of our women had no risk factors at all was a surprise. And the number of women, the fact that 10 women had 5, 6, or 7 risk factors, that was a surprise. Not that those risk factors were present in our population. We know that. It's how they interrelated. But Liz, perhaps just pick up the issue about recruitment, because I think that's key here as well.
Thank you. I just wanted to make another point around what's changed. And I think it's been quite difficult to keep up with this statistic. So pre-pandemic, our caesarean section rate was 22%. And we were high at Luton and Dunstable. And there was a national initiative to bring that rate down. As it currently stands, it's at 54%. So when you have a higher section rate, the resources that are required and the induction of labour increases. So it's the way we're delivering services has changed really rapidly and quite significantly. And that's not an excuse. That's kind of where we've got to. And we're not alone in that, because that's been a national profile. And I think that's why lots of services are being struggling nationally, because you need a completely different workforce to deal with that. And certainly going back to the midwifery recruitment. So when we had the first inspection, we had a very big vacancy. When we had the second inspection, we had a smaller vacancy, but still significant. Where we are now is the national cohort of midwives is much richer from a new grads perspective than we had a couple of years ago. So we're in a better position, I'm hoping, to recruit into the 68 whole-time equivalents that we need on top of what we've got already. So I think it's been multiple factors about why we didn't quite get to where we wanted to be. Well, we certainly didn't get to where we wanted to be in that gap between the CQC inspections.
And just to add one more thing, I think there's a worry as well that the caesarean section rate will go even higher, because who've had C-sections in the past few years, when they now have a second or third baby, are more likely to have that baby as a C-section. So the worry is that C-section rate really goes up. It may come down at some point, but it's going to go up. And as Liz says, that means you need a very different workforce and a very more use of theatres, for example, which means more anaesthetic staff, which means more theatre staff. That's the bit that we didn't cope with very well over the past few years. Just to say, first of all, Liz comes in. Obviously, obviously the report is a public report, so it can be read by anybody. But that report does specifically say that all the women they spoke to had a positive experience. So it's not that we're not reflecting that in this report. This report is about the CQC specifically, but the positive is that all the women they spoke to in their visits were positive. But we do have ways of picking up those voices.
I think absolutely. And while it's good to get a metric that most people have a good experience, we know some people don't. and completely accept that. So there's a couple of things we do. So I've said we've got a new patient engagement framework. Our MMVP are absolutely pivotal to linking with our communities. And one of the real benefits we've seen, particularly over the last year, is the NMVP are employed now by the ICB. They're formal staff within the ICB. They've been recruited. And we have two, one that works at Luton Dunstable, one that works at Bedford. And they are their role is to keep us on track from that community voice perspective, and they work with us to make sure that that's reflected in everything they do, that we do. They're in all of our meetings. They're our critical friend, and we've just recruited a new director of midwifery. We appointed them about a month ago. They'll be starting in May, and the MMVP. We had a very senior panel. The MMVP were on all of our panels to make sure that they felt content that we were recruiting the right person to help deliver and move our services forward from an improvement perspective. And going back to your point about making sure we hear when things don't go so well, in our perinatal assurance group, which is a group that our medical director chairs, it's an internal, but we have our region, our ICB chief midwife, and our NMVP on that group. We always have a patient story, and it's never the positive ones. It's the ones where things don't go so well. And our patient experience midwife, along with our MVP, reach out to those women, and where possible, not everybody wants to come forward, but either we'll do a video interview or an audio interview. So it's not just written down. We can hear the voices of the women in those meetings, and that happens every month. And that really helps us. And one of the things that helps us do is use that information where things haven't gone so well to make the improvements that are required, to make sure we've got that balance. You're absolutely right. We need to make sure we hear from everybody. And we have got that, and there's a whole piece of work going on in regard to that. The other thing, just to bring up the translation services, because it is we have got a translation services, but I think we've recognised that we need to make sure it's as timely as possible and as responsive as possible. And we're just rolling out a new program using digital translators. Now, that isn't a digital translator. That is a person who is a translator who we can access digitally. And we've got about 150 devices on wheels that are being rolled out from the 3rd of March. And we're piloting it in Luton and Dunstable Maternity Unit before we roll it out to the whole organisation. So we're really excited about that. I think it's going to be transformational for women that go to their community hubs to see their antenatal midwife, for women that are in labour, for women that are in a consultation, for women that are having a scan. So we can use them across lots of different components of our service. So that, as I say, that's going live from the 3rd of March.
It's certainly the case that we've undertaken a workforce review towards the end of last year. But it's not the case that we have not been doing anything. We've put, I think we calculated £7 million additional investment across our two units over the period of the last 5 years. So additional resource has gone in. However, going back to Liz's point, it's keeping pace with the way that maternity units have changed, which now are a very, very different service than they were then. And so I think it's been an ongoing process. This is a particularly significant investment that we're making, and should hopefully allow us to get to the point where we've got stability, particularly now, as Liz says, we can recruit. but we have not been not investing. We've been investing significantly. I think there's probably no other service where we've invested so significantly as maternity, despite the fact that the funding has not changed at all. And that's, in fact, a significant cause of our current financial difficulties this year, is because actually we've been had to make that choice without additional funding coming in. But the other thing just to say is, obviously the new unit itself has also driven additional investment because it's a bigger unit, so that has its own costs, big as a heat, big as a light, big as a pay rates on, and all the rest of it. Yeah, I can't honestly answer that question. It is obviously disappointing. The CQC are part of our perinatal improvement program. They're on the board that oversees it, and hadn't raised any concerns about our progress through that board. So it was a disappointment when particularly as I think certainly on the verbal feedback after their visit was mostly positive. So it was a really big disappointment that the rating did not change up after that. Having said that, clearly there were some areas that we'd not improved as quickly as we wanted to, such as appraisal rates, mandatory training, and our instant closure. But given the progress we were making and the progress that's been recognised in other visits, so for example, something called a 60 steps visit, which the region do, that happened. There's one of them just recently, which again complemented on our progress. So we think we're going in the right direction. We might not be going quite as quickly as we need to, but we're going in the right direction. And I think I think there's no doubt that we've been doing that since the last CQC report. And there's an almost enormous amount of oversight that goes on to making sure we are doing that. And so I can't answer the questions why the CQC ultimately decided not to change our rating this time, but I'm absolutely confident that we're going in the right direction. The question is what the pace of that is, and some of that clearly is determined by the ability to recruit staff. But we're in a relatively good place, so we can't use that as an excuse, because actually the time has never been better for us to recruit midwives over the last couple of years. Well, I think it goes back to the previous point that as that section rate has risen, we've been struggling to catch up with it. And I think certainly none of us would have predicted it would reach where it is now. So but fair to say, maybe we should have predicted where it's going and where it might continue to go. But certainly pre-pandemic, we would never in our wildest dreams have thought it would get to 50% C-section rates, and that's obviously for all sorts of reasons. And it's the case that not just the elective has risen, but the non-elective C-section rate, the emergency section rate has risen as well. So it's not just women's choice, although that's a part of it, but it's also the fact, and it's partly the fact that as time has gone on, new standards of intervention have pushed the C-section rate up, but also the fact that the risk averseness, because there's so much scrutiny on maternity services, that now clinicians are likely to intervene perhaps earlier than they would have intervened before. And you put that alongside the women's choice, and we've ended up with where we are now. So I don't think we are unique. I don't think any unit predicted where C-section rates would be, but we have to deal with it now. But I think it's absolutely fair to say that we struggle to catch up with it as it would continue to rise and rise and rise. And perhaps when it's 30%, we thought, well, it must plateau now because it's 30%, and it didn't plateau. And when it's 40%, we think it plateau, and now it's 50%. And maybe even now we're thinking it will plateau. It can't go higher than 50%. But there are countries in the world where the cesarean section rate is 80%. Brazil is a good example of that. So it is not beyond the predictions that it will get even higher. And clearly that's not happening in every country. In Europe, for example, I think our section rates are higher. So particular things that are happening here for whatever reason that are driving the C-section rate to be what it will be.
So that's a lot of people, and there's a different profile of some of those. Some of those are senior midwives, and some of them are more junior midwives. So I think there's about 44 more junior midwives that we need to recruit. So what we need to make sure that we do is when we recruit, especially new graduates from university that have just qualified, is that we give them a really positive work-based support and induction, which will run over a period of 18 months. We call it their preceptorship time. Because if we can get that right and support them in their clinical practice, then they will stay, because we need to create the senior midwives for the future. I'm talking specifically about midwives. So we have developed, as part of our board paper, a trajectory of how we would recruit those midwives in numbers. And it's going to take us a little while to do that, because even if we put an advert out today and 48 people applied for that, we couldn't manage them all in one go, because then we just lose them. So we need to give them a positive practice environment. And I think that's the bit for me that we are changing. So what we're going to do in order to do that is every couple of months, we're going to try and recruit some newly qualified midwives. We're going to increase the number of senior midwives that support them just specifically to do that. And then as time goes on and they become more experienced, we can drop those, that's it. The profile of that workforce will change. So it's on a trajectory. We are creating a workforce summit to look at how we recruit and retain and develop. It's not just about recruiting, it's keeping and training and staying and providing people with a satisfactory and enjoyable career, because at the moment the pressure is really on all of our medical and midwifery workforce. So it's creating that positive practice environment for them to develop and grow for the future. And our staff are immensely proud of working for Luton and Dunstable and Bedford hospitals, and we want people to feel the same. Our new staff that are coming through to feel the same, despite the challenges. So the Workforce Summit will include us as an organisation, and also we have our national team that are supporting us, coming up with more creative options about how we can do that, and also our local university, because they give us our pipeline of new graduates. We want to make sure we're supporting students so they want to come and work with us once they qualify, and that we can shape curriculums to make sure they meet the needs of our communities and vice versa. So we're approaching this differently than we have done before. Rather than just putting an advert out and trying to recruit midwives, we're having a different approach to it.
Just one important point, which is worth making, I touched on it before, but that maternity services are difficult because they are volatile, essentially. So at Luton, we have 14 births a day on average, but on our quietest day, we have 7, and on our busiest day, we have 23, I think. So you can see how it would be great if births just happened and there was the same number every day. That would make our workforce. It's not just about sometimes the number of midwives, but it's how you organise them and how you particularly deal with escalation. So when it's particularly busy, what do you do then? And are your processes right to deal with that? And I think that's what can make it very difficult in terms of if you're a midwife working on the shop floor, how does the unit cope when it gets really, really busy? That particular profile is much more severe in terms of the variability than I think any other service that we run. It's much more volatile than the numbers that go to A&E, for example, because of that, because you've got small numbers basically.
Thank you. That's a good question. So we have, as part of the Birth Rate Plus review that we've done, we have increased, and they're already in post. Because we got some recognizing that governance of risk was an area of challenge. We increased our staffing cohort within there, so we've got some more senior staff within there. And as part of the Birth Rate Plus, we've had that approved at board. So we've got a substantive cohort of a central governance team. In regard to the training, one of the challenges we've had, and you'll see it it's in the report around our incident management, is because we have seen an increase in the number of incidents reported, and that's not because there's more harm occurring. It's just the team have got better at reporting incidents, and reporting incidents is a healthy culture that we want to encourage as an organisation, and we like to think it creates a openness and transparency and willingness to learn. One of the challenges we've had is completely closing them down, and there's several stages to getting to that point, and there's several variations of level of investigation that are required depending on the incident. And one of the challenges we've had going back to the operational pressures on the shop floor is making sure our obstetricians and senior team have got the capacity, not necessarily they've got the skills, but have they got the capacity within their daily working lives in order to help close those incidents down. So we have a central team, but we still require midwives and obstetricians that are working on the shop floor to get involved in that time that's dedicated to closing some of those down. And that's been some of the challenges, because going back to the issue we've had again with mandatory training, if the shop floor is busy, the safety of the shop floor has taken priority, which has been the right thing to do. And I feel confident with this increase of staffing that will allow our leaders to do the leading they can do to release teams in order to manage some of these issues. So it is a real challenge, but we've got more staff in that team than we've had before. Unfortunately, Amrita Viegas, who was our clinical director, was hoping to come tonight. Unfortunately, she's had to fly to India for personal reasons, but she's working with her obstetric colleagues as well. It's not just about midwives, it's about doctors and midwives having that time to do these investigations and close incidents down so we can feed back to families.
Thank you. Good. Just for Councillor Moore next, but can I just follow up on a couple of points that Councillor Begum has made about talking about the audit of risk factors that happened last November, and you were saying that the results of that came as a surprise. Does that a couple of other things that we've been speaking about, does that indicate certainly up until this point, until the point of the CQC inspections, that there was a lack of curiosity about what was going on in the maternity department? So if management doesn't know what is going on in a department, then how can you tell what issues, what problems there are, if it's working well, if it's not working well? So for what you're saying, I'm getting an understanding that that is beginning to change. But is that a fair statement that there was a lack of curiosity previously?
It certainly wasn't lack of curiosity. I think it was lack of data. So one of the things we did a manual audit. I haven't mentioned this yet, but one of the things that we absolutely need to do, and there's a transformation program happening this year alongside all the other things and the improvements, is we need to be digital. So there is a new electronic patient record being implemented called Badgernet. So that's for our maternity service. It's exclusively for maternity and our neonatal service. So it will go across community, hospital, and across all care settings that deliver maternity services. So I think having a digital system will give us much richer data than we previously had. Now, what the audit that we carried out, that's what staff were telling us. That was the anecdote. We did the audit. We know once we've got our digital platform implemented, we'll be able to plan things a lot better. At the moment, we're very paper-based for our service. So see a community midwife is paper-based. If you come into the hospital, it's paper-based. So that is a real challenge for, and that's a big focus on improvement for this year, because I think once we've got that, it will be better for the women, better for our staff, and better for the information that we hold on our services.
Sorry, Dave, were you going?
Yeah, just to say as well, and perhaps it shouldn't be categorised as a surprise for us. In fact, when I've been the trust for a while, back in 2013, when we used to categorise women for payment purposes by 3 different categories: low, medium, and high. It was the case then that Luton and Dunstable had the highest number of medium and high risk women in the country, and I still think it's probably the case now, and we probably do believe that it's probably no other unit that has the level of risk profile that we do, and that goes back to my point. It's because we're a district general hospital with a complex demographic, but also we run a tier 3 neonatal unit, which brings in high risk women from the wider catchment. So it's perhaps this audit doesn't prove it because we don't have any relative data, but it's certainly, if not the most, has the most risk profile of any unit in the country. It's certainly probably in the top 5. So it's not a surprise. I think goes back to my point is, I don't think a lack of curiosity, but it is a lack of data, and it's how these factors interrelate and their impact on workforce. So we do intend to carry on doing this, but it shouldn't be presented as though the overall issue is a surprise, but the actual reality of that data is definitely what our midwives and clinical staff have been telling us is their experience on a day-to-day basis, because that drives the amount of resource that they need to put into each pathway, and that's what's created the challenge.
I appreciate what you're saying about gathering data and how useful that is, but it's not just about gathering data, is it? It's also about management taking an interest, just having, going back to that word curiosity. I mean, what is happening in the department? Are things going right? Are things going wrong? So when you had the first inadequate rating from CQC back in 2023, I mean, was that a surprise, or was do you, or were you expecting that rating?
It was not a surprise that our units were challenged, and significantly so. We absolutely knew that. And I mean, I think the question of, single word ratings. I mean, certainly in the past, the inadequate rating was reserved, I think, for units where you had a problem and didn't know you had a problem. Now, whether that was the case in the past, it certainly is not the case this year. Myself and Liz, as the two executives who probably have most to deal with maternity, spend more time on maternity than any other service by some distance. So I don't think there's been any lack of curiosity about the service. I think there has been different interpretations of the problem and where the problem lies, and certainly different interpretations about what the future might bring. But there's been no absence of curiosity about the service, and no absence of the time that we spend both trying to understand and analyze the problem or the problems we face, as well as talking to staff about their experience of it. And we've had the most L&D in 2025 has had the biggest single new building it's ever had in its history. So that move, and maternity obviously at the heart of that move, because two of the four services which have gone into the unit are maternity and neonatal services. So I don't think there's any absence of oversight or interest from us as management. But as the chief executive, I have to take responsibility for the fact that we didn't get our rating change this time. But we're determined to make sure that will change as quickly as possible. And we're hoping the CQC comes back quickly, which they should do because of our rating. And we think we've got a good story to tell.
Okay, thank you. Councillor Moore.
Let's bring a couple of issues that were raised earlier on. A bit more to do, because obviously we talk about new building and stuff like that. But the one thing we can obviously control is the relationship people have them from the minute they enter the door. And a couple of things you raised. You mentioned about digital translators. I'm just trying to get my head around that. Is it basically like a Zoom call on wheels that can go around? So they can see, because obviously in any situation when you're trying to translate, body language can come into that, and tone and
Absolutely, it's a real person. It's not it's not AI, or it's not just a voice. It is a real person that you're talking to.
and they can
they can
see the person who's
because also
speaking.
so it translate. We can access all different types of interpreters.
Yeah.
Because we also use British Sign Language as quite a significant amount in our service, and that is a shortage translation service, and we've had some real challenges getting that, but this will resolve that element as well.
And then you talked about obviously training midwives, and I was pleased you mentioned retention, but when you've looked at why all maternity staff have left, the ones that have, what are we doing to look at exit interviews, and do we have any data on why people leaving from maternity services are leaving the L&D, and whether that fits with national trends, or there's a specific issue that's causing us to lose experienced people from the maternity teams that other units aren't?
I think we're quite good at keeping our senior staff. I think it's so after the pandemic, we lost some senior staff because some people maybe that were going to retire a couple of years after the pandemic decided to retire a bit earlier, or people reduced their hours, or they went on the bank. So there was a real shift, and that wasn't just us. That was a national trend. I think the where we see a higher turnover of staff is in that first 12 to 18 months post registration, either as a nurse or a midwife, but we're talking specifically about midwifery staff.
Yeah.
That's where we see the highest proportion of people leave the profession.
Yeah.
And whilst we do try and capture exit interviews, by the time someone's handed their notice in, it's
Yeah.
too late. They've
I
already
appreciate it's not
thinking
always easy.
they're going. So this will be a focus on actually trying to catch them before they get to that
Yeah.
point where they feel they need to, there is no other option to hand their notice in. So that's why the different level of support around that first 18 months is so critical, and making sure that they've got a clearer career pathway about what their options are, because there's lots of, we've got 40% of the service that we provide is done in the community. The hospital is just one element of it. So there's lots of options. It's being clear on what those are and how they can get to where they want to be.
But
from
yeah,
a
but
career.
again, though, that issue regard that area of 12 road, that's not a specific LD and Bedford issue. That fits with national trains, doesn't it?
Okay, is there anyone else? If not, I've got a few questions. I think to carry on from what Councillor Bacon was talking about staffing, the recruitment gap. Hopefully we're not going over what we've already talked about, but so there's a plan to recruit those 66 WTE. How are you planning to cope with the situation while that recruitment is going on? Are there other plans in place to cope with the workload while that recruitment is going on?
We will use temporary staff, so that's our cohort of midwives that do bank. We have got some midwives that just do bank, so we will utilise our bank. We have got some agency midwives as well, that we have recruited some. So what happens with agency midwives, it's not ideal, but we have got some excellent agency midwives. Although they might be working in an agency, we employ them as long lines, so we'll put them on the roster, they'll have a local induction, and we have got a number of them as well. I'm not suggesting it's going to be completely straightforward, and it's going to take a little while for us to do this to make sure we don't lose anybody along the way and people get a good experience, because the workforce plan will probably take about 18 months and 2 years to 2 years to fully implement on our substantive staff. So we'll be utilising temporary staff, giving for the time being, accepting that there will be days when it is challenging and we have to reprioritise how we do things. And I think, as David said earlier, some days are going to be easier than others, because some days you'll get 7 births and some days it will be in the 20s. So it's just managing that different capacity on a daily basis. And this is what the leadership team do day in, day out, every day. So we have got a very good response to that. The other thing we use is we've got an acuity app that we use 3 times a day in both units, which it's a bit more sophisticated than just the number of women that are in labour. It's called a Birth Rate Plus app. So what it does is it matches your demand to your staffing. So you can get a better idea on a daily basis what that safety looks like. That's from a midwifery staffing perspective. So we utilise that in all of our reporting, and they use it as our escalation when things are getting where they need some additional support. And sometimes that might be an internal escalation from the site team, or sometimes that might be an external escalation, depending on the status. So we have to make sure we've got a responsive service, because nothing stays in a linear way.
Okay, follow up. Yes, sort of following on from that. You're talking about new senior leaders and new clinical director. Are those people in place?
We have got a new clinical director that started
last month.
last month. She was coming tonight, but unfortunately she couldn't make it. And we have got a new director of midwifery who's starting in May. Our current director of midwifery is retiring. She's had a long career in the NHS, 40 plus years, but she's decided to take retirement, so she retires in March. So there will be a new clinical leadership team.
Okay, and is that management team's is that been strengthened? Is that stronger than it was before, or is it basically the same structure as before?
I think we have got it's a similar structure, but one of when we've had all of our external oversight, both from a national, regional perspective, we have got good senior leadership structure. So I don't think there's an issue with structure. We've got a very experienced director of midwifery coming who's been a director of midwifery in 2 other units in the country. So,
Okay, thank you.
who is familiar with Luton and Dunstable, who has worked there in the past.
Going on to where the CQC were talking about continuous improvement and a learning culture. I don't think we've spoken too much about that so far. So one of the criticisms was that that there isn't a proactive, positive culture based on openness and honesty, and that lessons were not learnt to continually identify and embed good practice, and that delays in the resolution of incident investigations risk leaving underlying issues unresolved. You've spoken about incident reporting and how that's being dealt with, and that's encouraging. Could you talk a little bit more about this idea of having a proactive, positive culture, positive learning culture, and learning from experience, and embedding that learning in good practice?
So, incidence is one element of learning. But when we set up the perinatal improvement programme, we have programme management support, and our transformation team in the organisation are completely plugged into our perinatal improvement programme. And our transformation team are responsible for the QI element within the organisation, so the quality improvement team as well as the transformation team. Within our governance team, our head of maternity governance has got QI in her portfolio as well, and education sits with her. So this is around, so that function is, we have QI that sits in our governance team that plugs into our complaints, instance and learning, and then we can take the training out based on, because the education team sit in there as well, to make sure we get that learning across the team within maternity. That also will involve the medical and midwifery. It's not just about midwives, it's around that whole MDT approach. And we will then use that, and I think it's in the paper. So we had an issue with some of our guidelines being out of date. And what this has given us the opportunity to do is make sure that we've got not only the best practice guidelines from a national perspective, but we've been able to take any learning that we've had out of incidents to shape and realign some of our guidelines and standard operating procedures within the organisation. So that is absolutely our intention of where we need to get to, and that's what the perinatal improvement programme is designed to do. But that takes time, and it requires capacity of teams to be able to do that, as we've already discussed.
So the idea is that all of these aspects of learning and improvement, training, and the incident report, it's all going to be integrated and presumably sustainable over the long term.
And that's exactly what the perinatal improvement programme does. All of those components are within that, and even what we have recognised as well is because of the scale of and complexity of all of many components of maternity and neonatal services, particularly within our organisation. Even if we get a good CQC report, or if anything, hopefully things will change, and we feel that we're more in a business as usual state, we still need to be plugged into that programme of people that are designed to run programs of improvement and project management outside of the skills of the clinical staff that are trying to provide the service. I think that's one of the things that we've really recognised, that it requires that program management, as well as in order to keep everything on track and make sure we might comply with the CQC actions, and there'll be some other actions that we'll focus on, but we've got that continuous monitoring of all of those things moving forward.
Okay, and there's a recognition that it's not this is not just an end in itself, is it? They're doing all these implementing all of these improvements. It's all about improving outcomes and guaranteeing the safety of mothers and babies within the unit. Presumably,
Absolutely. But it's the sustainability bit, so that we don't, and it's a big transformational program. So we've got the CQC report, but this is a transformation program that involves digital transformation and all of the things we'd expect, so that we can make sure that we have got a service that's fit for the future.
Okay, just one more from me. We're talking about the culture, and have you noticed, is it a measure? Have you been able to measure any improvements in the workplace culture?
We do run into it. So we've got the work stream that's associated with looking after our people. So that is something that our EDI leads do test on an ongoing basis. I spend a lot of time in the units. So does our non-executive director, who's responsible for maternity, the board level safety champion. We're just going through a transition of change there. I think one of the things that we have seen is we have got more employee relations cases that have come to light. And whilst, one could argue that's not a great thing, but actually, I think people are speaking up where things, maybe there has been poor behaviours that require investigating. So we have got some complex employee relation cases which we are trying to deal with as well within the service, which we've seen more of over the last year. So I think it's small bits of, it's not one thing.
Yes, because one of the things that the CQC report mentions is that up to date, or to the date of the report, there was a there was a deficit in openness and honesty about these issues, but you seem to be saying that that's starting to change.
I think it definitely is, because we've got the Incivility and Anti-Racism Charter, which was done with the team in the service. This wasn't written by myself or the director of the referee. It was done by the shop floor team, and it's just constantly working through that and making sure that's really clear with teams.
And just to say, I think we took some assurance from the fact that some of those issues of racism and incivility between staff were not a feature of the most recent CQC report. They were a feature of the 2023 one, but the work we've done since then, I think, has shown fruit. The other thing just to say is, obviously, all staff in the NHS not all staff, but staff are encouraged to take part in the National NHS Staff Survey, and that does give us good data on our staff by department. We're just waiting for the results of that. We should get that in a few weeks. That happens once a year, and so that's another useful barometer of whether we're seeing progress between years. So we'll know that quite soon.
Okay, does anyone else have any more questions? Councillor Hussain.
I didn't want to. Okay, let her, please. What I was going to ask you in terms of changing the culture, which I didn't ask you too many to start with, because my colleagues obviously have a question too. In changing the culture is the most difficult because people have got into a habit and changing that different pattern of work. What has gone on in the past? I mean, how can you assure the public and us in that sense that there will be a service major change in the culture of the whole organization where these things have gone on for some time?
Well, I mean, it's obviously difficult to provide absolute assurance, but as I said, one example is the fact that the CQC this time haven't picked up some of those issues they picked up first time, and some of the data we can produce through our own surveys, but also through that many things that Liz talked about in terms of, for example, the complaints data that we've got, the feedback we get from our patients. We have to put all that together. I mean, we have a big service, and there'll always be some examples of that, but I don't think I think most of the staff in the service are very proud of the work they do. That we have staff treat our patients with dignity and respect and treat each other with dignity and respect. But there'll always be incidents that where that doesn't happen. It's how we act when that takes place. But I think we are as confident about the culture within the unit. But the way that we have to demonstrate that is through our data, our outcomes, our complaints, as well as through our own staff survey. The staff survey can sometimes be more valuable than patient surveys, and we know that throughout the NHS. And so there are two very comprehensive surveys that take place, one of patients and one of staff every year. So we have the feedback from that, which does provide some of that assurance. It's not. I mean, nationally, maternity units are probably in a situation where their staff surveys are not as good as the average for the rest of our departments because of all the challenges they face. But what we need to see is it going in the right direction. I think it'll be doing that this time around.
The other question I've got is for you is, I mean, from experience from the hospital, you've got a very diverse staff in the hospital. What was surprising for me to read the first CQC report of racism, particularly among those staff, among some of the black mothers receiving certain racism, and I just couldn't believe that this would come from a very diverse. It was just one sort of staff, but not a diverse culture staff. That would be the case. That is a surprising one. But what's your practical experience of that? How did that happen?
I mean, we have one of the most diverse workforces of any trust, which reflects our population. But I do think there were particular circumstances in the way that some of the issues in the first report happened, in the sense that we did. The issues primarily related to midwives who we'd recruited from overseas, and there was tensions and friction between that arose in that situation. I think other units have seen that, where it's not necessarily about racism. It's not just about racism. It is also about actually different working practices from individuals who've come from different maternity units overseas, who do things in very different ways, and maternity units do vary. So I think it was a particular circumstance of that time. Going back to my point about the surveys that we do have an enormous amount of data which tells us about levels of racism that goes on between staff within our hospitals. But and that gives us some assurance about the levels. I mean, we have 10,000 staff, so to say that there will not be racism in our hospital would be completely wrong. And we know that from the survey. We know that from the national staff survey. We know that from our own staff survey that racism does happen. I think perhaps it's fair to say that the report that happened in 2023 enabled us to actually be much more open and honest about that, and I think we were, and I think that's been a really good thing to say, yes, we do have some racism in our unit, and that's allowed us to do things which Liz has referenced, which I think have had a real impact. And as I say, the assurance that that's not been a feature of this most recent CQC report. But I think racism will happen in our hospital, given the size of it. It's about how we deal with it when it happens. And as Liz said, the fact that we've sometimes when you have you make sure you carry out the right processes, and sometimes disciplinary action is necessary. Those are the important things in terms of the way that we respond as an organisation. But I think being open and honest about the fact that it will exist is really, really important for us, particularly given our population and the diversity of our workforce.
Do you have a sort of zero tolerance in terms of racism? Does the staff very well aware of that? Yeah.
But I think that the work that we've done over the last couple of years and some of the work that we've done as well to sort of have the conversations about it, because I think and particularly given the diversity of our workforce, it's not just a white, non-white issue. There's lots of different issues of discrimination and potentially bias within our workforce, which we have to understand as a particularly diverse workforce that we operate. And we've done several things over the last few years. For example, we have a staff engagement event, which we had one last summer, which took unconscious bias as its theme. So we do lots of work with our workforce to talk about these issues, and I think bringing them out into the open, discuss them, and accepting that it is part of the reality that we have to deal with as a organisation which employs 10,000 staff.
Can I ask you, I think I asked you earlier on, but can you give us an assurance to the patients, the people that are, residents of Luton, that the maternity services in Luton are safe for the mothers as well as the children?
Well, I think the best way of doing that is looking at the outcome data as well, and I mentioned that. I mean, I think clearly that all maternity units will have incidents of certain kinds. All units will have hemorrhage. All units will have tears. All units will have potentially sometimes neonatal deaths or stillbirths. We know that, and it would be wrong to suggest that maternity units of all kinds everywhere up in another country have those. But it's also important for we look at the data, and we understand our data and how we compare to other units. And as I said, some of those factors that we look at, not all factors, but some of the key factors that women will be interested, hemorrhage and tears are two that women are very interested in. We're below the East England average, and we need to continually monitor that. Particularly given the fact that we've got a more difficult and complex risk for our women. So I think the question of, I don't think we should be glib about, is the unit safe? I think we should always be curious, going back to the chair's point, and constantly monitor our data. But I think we also have responsibility to reassure our women that actually they can have confidence going to both of our units. Our outcomes are good. The feedback we have from our women is, in the vast majority of cases, very good, very good. But we also then have to be honest that sometimes things do go wrong. But also when those things go wrong, we're determined and committed to, one, being transparent about it, but also making sure that we can learn from that to make sure we don't in the future. And I think that honesty, that things will happen, things do by the nature of a maternity unit, there will always be instances, but the transparency and honesty about it is the most important thing.
It's a comment now, not a question. Last thing I would say in positive terms, that just about when the inspectors were there 13 months or so ago, my grandson was born in the hospital, and the service was excellent. So I can say that was very positive and personal experience.
Thank you. Councillor Arls?
Thank you, Chair. Thank you. I just want to ask, paragraph 25, it says here at the last bit, it says, section 25, sorry, as a result of this early supportive intervention, some concerns are resolved at an early stage and are appropriately downgraded, improving both experience and efficiency. Is it possible to get the percentage of those ones? You probably won't have it tonight, but if you could provide us with the percentage figures. Sorry, it's number 25, and you're saying that you've had intervention, and some have been appropriately downgraded, improving both experience and efficiency, and the concerns are resolved at an early stage. But could we possibly have like some percentage figures of, yeah, if you could, if you haven't got it now, and that's fine. And I just want to ask, because obviously I know time's fast spent, workforce representation. I just want to find out what percentage of senior maternity leaderships are from the ethnic minority backgrounds due to the high level of South Asian and African Black Caribbean people in Luton. I just wanted to find out, have you got those percentage figures for us, please?
I can get those figures.
If
Yeah.
you could,
Yeah.
because and also the other bit is just it's about community engagement. I just want to know what changes have been made with the community by the trust to engage with the South Asian and Black community, African community, to get in outcomes and to find out what the specific issues are. How much engagement have you made with the actual communities, like the faith groups, the community groups in the
So
trust?
I've got a list here that somebody pulled off before, which I'm happy to share as well around
If you
all
could
of
share,
the
that's fine, not
activities.
now, but if you could just
So,
send it out as well.
happy to share the last quarter's activities around our community engagement that we've done.
Okay, please do, yeah.
Yeah.
That's important. Thank you very much. Thank you, Chair. Thank you.
Councillor Moore, you asked the question? Oh, okay, right. Okay, so if there's no more, I'll do quick summing up. So as you mentioned, maternity outcomes are good, but I think it's important that issues with processes are tackled. It should be obvious that the problems with processes can be indicative of potential risk and problems that are going in the future. I think from what you've been saying tonight and the impression I'm getting from the report is that you're aware of those issues and that you're putting in plans in place to deal with those, and it seems that in the cases of incident reporting and mandatory training, then the direction of travel is already in the right direction. Yes, and you spoke about putting in place a sustainable improvement plan, which I think we should find reassuring, and hopefully that will produce positive results over the next few months. I guess it's a good time to think about when we would like you to come back and report again. So. Do you have any idea when the CQC are coming back? Right. Is this it? I mean, are these visits unannounced? Or right? Okay. So would it be reasonable to take this discussion offline as to when would be a reasonable time to come back to report to this? Yeah. Okay. Right. Yep. We appreciate the fact that you've come here tonight and given this report, second time in a week. So yeah, thank you very much. Thank you. Okay, we move on to item 8, the Mount Vernon Cancer Centre consultation. Kelly?
Good evening, Councillor. Good evening, Chair. Hopefully this should be a bit of a quick go through this paper. Attached is the Mount Vernon Cancer Centre. It's a public consultation that ends in March. I'm seeking views from different statutory groups across the council in terms of contributing as a council to the public consultation. So fundamentally, the key points are that 5% of Mount Vernon Cancer activity, or those people are accessing services at Mount Vernon Cancer Centre in Northwood, in Hillingdon, are from Luton. The public consultation sets out that the current location, the current facilities need to be changed. It's not an option to continue running Mount Vernon Cancer Centre at its current site in Northwood. It's not fit for purpose, and it can't deliver the advancement in technology that it's needed to treat current cancers. And the paper sets out some of the examples of the additional technological advances for cancer that need to be provided in order to deliver the best services and the best outcomes for people with cancer in this area. One of the key things that they've identified is that because of this new technology and the advances in medicine, services do need to be located adjacent to an acute hospital service. This is, for example, for emergency medical interventions, cardiology, and A&E services. So the proposal by the current commissioners, which are East and North Herts, is to relocate the service to a dedicated site adjacent to Watford General Hospital. This site is the closest location to the current Mount Vernon Cancer site, which covers a catchment area of Buckinghamshire, Berkshire, Luton, Bedford, and so quite a broad geographical catchment area. So the main proposal has three options. Option A is it solely relocates to this new adjacent site at Watford General Hospital. Option B is that it is the same as option A, that relocation to that site, plus to have a networked radiotherapy site at the Lister Hospital. And radiotherapy, as you'll appreciate, is one of those cancer treatments that people have to travel every day for up to 6 weeks, and it's a long trek when you're receiving that treatment. And the third, so option B is to relocate that radiotherapy unit to Lister Hospital, and option C is to relocate that networked radiotherapy unit to the Luton Dunstable Hospital. Now, as far my recommendation in the paper is that as a Scrutiny Committee, we should be going for option C. It is the single option that delivers the best access to services for Luton residents, and fundamentally, it's the one that will provide the best option for our residents in general. So I'm seeking advice. Well, I'm seeking a recommendation. Is that as a Scrutiny Committee, we contribute to the consultation. My second recommendation is that option C is the best option for Luton residents. And my third ask is that if there are any comments that you would want me to submit with the consultation, I'd be happy to take some notes of them and submit them. I'm just going to grab a pen.
Okay, Councillor Moore, then Councillor Bogan, then Councillor Hussain.
Just a couple of things. Because Mum recently had an operation on Watford General Hospital site, so I'm kind of, I favour where. So where adjacent to Watford General Hospital would the site, sorry, where adjacent to Watford General Hospital would the site be? Because there's not a huge amount of room there.
No, it's a dedicated site actually on the grounds of the hospital. So it's actually the same location, but it's
on the site itself.
Yeah, so they're referring to it as being adjacent to, but actually, if you look at the kind of the aerial planning photos, it's actually right next door to the main build, or right next door to the main site. So if you travel to Watford General Hospital, you will be there.
Yeah, fair enough. Just a second thing, on all the documents that you talk about the reduction in journey time, I've just done some quick maths there. I'm pretty certain that those times are just driving times based on those times. Now, I appreciate that none of the options other than Luton are particularly well served by public transport, and to be fair, there's not a huge amount of difference between the current site and Watford or Lister Hospital or any of the other options. I'm just aware that when you look at these documents, those times don't reflect the people that wouldn't be able to drive.
So the travel times are the timings that are in the consultation document. It is fair to say that travelling to Watford is easier than travelling to Northwood. I suppose what I would really stress is that there is no other option to locating the main site to Watford General Hospital. The options are purely as to the networked additional unit, which would make it easier if we had it located at Luton.
No, and I certainly agree with option C. It's just a point that when you see, if the public see this, and those that aren't able to drive themselves, like I'd take time off to drive my mum to Watford, and actually the journey's not that bad, other than being able to park at Watford, which is but anyone looking at the document, a member of the public who wouldn't be able to drive would say that journey time isn't right. Do you get on?
Can
Not
I
me.
just say there is Dial-A-Ride available for cancer patients to travel there, isn't there?
Yes, there is some dedicated transport to make that happen. But that said, if you're traveling every day, 5 days a week for 6 weeks, it's exhausting.
Thank you, Chair. I do see the option C is good for our residents. So let's say we agree for option C. What guarantee do we have that the radiotherapy unit at L&D will definitely be developed and delivered, and by when?
As part of it's part of the public consultation. So as an option, it will have to be taken in terms of consideration. Whether that is the chosen option is outside of our gift. The actual consultation clearly states that they are open to all considerations. So regardless of our input, the final decision won't be made by us. It is merely our contribution that we're seeking. One of the things that it does say in the consultation is that the running and the responsibility for Mount Vernon Cancer Centre will move from the Hertfordshire Trust, and it will move to Specialist Cancer Services. So I think that's a positive in terms of being able to fit into the kind of the national system of cancer centres. But there is no guarantee that the outcome that we would want is going to be the outcome that's going to be delivered. But the fact that a radiotherapy unit at the Luton Dunstable is being considered as part of this option means that there has been some feasibility study. And I think over in the last 10 years, there's been an ongoing discussion about locating a radiotherapy bunker at the L&D for many years.
Thank you. I think my colleague here asked the questions. What I want to know, like you just said, if someone were to travel every day to Watford General Hospital, has that been assessed? So if they have to go there every day, someone has to go to Watford General. Has that been assessed properly? Especially people who are on low income household or can't afford it?
So if the cancer centre, if option A it becomes the option, which it means that it will solely be provided from Watford General Hospital, if the prescribed treatment, which is often the case for radiotherapy, 5 days a week for 6 weeks, then people will have to travel. Hence why option C or option B are better alternatives, because it provides access to part of the catchment area that is furthest away. So if we were to get a networked radiotherapy unit at the L&D, that 5 days a week, 6 days for 6 weeks would mean that the Luton residents would travel to the L&D and would only have to travel to Mount Vernon for very specialist interventions, because part of the consultation is also to provide sort of local outpatient services, so things like bloods and the things that perhaps people did travel to Mount Vernon for, that would be provided at local district general hospitals. So when we're fundamentally looking at the provision, here is what they're specifying is the provision of the specialist elements of the cancer centre.
Sorry, I think you misunderstood my question. Let's say they choose Watford General Hospital as an option, and if someone has to go there, we don't have L&D. Has that been assessed? How would someone travel? Has that been assessed? Sorry.
Or, Councillor, you might have to clarify what do you mean by has that been
So
assessed?
if they go with the option A, like you said, the radiotherapy will take place at Watford General. Okay, there's nothing in Luton. So all of our residents who are on the treatment, they would need to go to Watford General 5 days a week or for 6 months. How will they travel? Has that been assessed properly? That's what my question.
The same provision would apply that currently provides for Mount Vernon. So it's either people would have to travel under their own steam, or alternatively, the patient transport services that are currently being provided, if that's the case. So that for us would be a possible outcome. But the fact that they are offering local radiotherapy units at either like Luton Dunstable and the Lister Hospital does show an advance from where we currently are, which is everything is based at Mount Vernon.
If let's say we want option C, like you said, is good for our residents. If that doesn't get chosen in the consultation, are we not able to show a viability assessment to say actually option C is better for the residents here? Are we not able to do that?
I'm sure we can do, but the public consultation is the public consultation. So, I mean, the fact is that it will all be part of the overall picture, which is hence why I'm going around very different groups in terms of a critical mass of trying to encourage as many people as possible to submit towards this public consultation. Option B and option C would be better solutions to option A because it does provide that greater access. But out of B and C, for Luton residents, we will definitely want C. So, we don't have any control over what the outcome of a public consultation is, and I'm sure that, like other public consultations, they may well be appeals, but we need to go through this process to actually get to a decision.
Yeah, can I say to you, somebody who did travel to Mount Vernon over 18 months with my wife, any alternative is better. I know that how difficult it is, right? And how painful it is. To be honest with you, I wouldn't want that anybody to experience that, because that is the most awkward place to get to. And to come there almost every day of the week, and then a chemotherapy, and then the radiotherapy at the same place, then going for the examination each time is not really very pleasant. Any change better than that is excellent. And I would go for option C if that is possible. At least chemo takes a lot longer than radiotherapy. But there is a public transport to Watford right on our doorstep. There's nothing to Mount Vernon. So those of us that have experienced this, it's bloody awful journey. I wouldn't wish that on anybody.
Okay. So just to add that the Mount Vernon J Hosk looks like it's being reconstituted and is meeting on the 13th of March.
Saturday morning for local consultation.
For the local consultation, yeah.
Yeah.
But there is there was a scrutiny committee that met at the end of over a couple of 3-4 meetings, end of 2024, beginning of 2025, which then which put in place a public consultation, which then fell foul of the local elections in 2025. So it looks like that process is starting again. So I guess then, yes, that this committee can support option C. Pat?
I just say we've got lots of information at Health Watch about this. We've got leaflets that we can share in the community. We've got the whole consultation and everything, because this has been going on for many years, but we've been supplied with lots of information. If you have organisations or anywhere that we can go and share this, we'd be quite happy to. Yeah.
Okay, thank you. Yes, we can do that. Okay, move on to the last item, the forward work plan. I think we can
Sorry, Chair.
accept
we
those
wanna
recommendations.
take
Sorry,
do we want to take a vote on that? Just to.
sure, yeah. Okay, is all those in favour of supporting option C? Okay, carried. Thank you. Okay, I think unless anyone has anything to add, we can accept the recommendations for item number 9. And if there's nothing else, I'll close the meeting. Thank you, everyone.